Managing acute abdominal pain in the emergency department begins with physiological stabilization. Before any scans are ordered, the clinical team administers intravenous analgesics for pain relief and anti-emetics to control nausea and vomiting. Simultaneously, continuous monitoring is established to track vital signs, specifically heart rate, blood pressure, and core temperature. Once baseline blood samples are drawn, looking closely at white blood cell count and C-reactive protein to gauge systemic inflammation, intravenous fluids are started. This stabilization sequence is required because it halts the immediate progression towards physiological shock or sepsis. It buys the clinician the necessary time to safely initiate the diagnostic algorithm. With the patient stable, the focus shifts to calculating the probability of appendicitis using a non-invasive triage tool, the Modified Alvarados score. Often utilizing the MANTRELS acronym, this scoring system assigns specific point values based on the patient's presenting signs, reported symptoms, and those baseline inflammatory lab results. This table outlines the clinical implications of that final tally. It maps the total score to specific probabilities and determines the immediate next steps in management. A score of 4 or less indicates that appendicitis is unlikely, directing the physician to evaluate the patient for other causes of acute abdominal pain. On the upper end, a score of 7 to 10 points signals that the disease is probable or very probable. This pushes the patient directly towards the surgical track. The critical diagnostic friction point lies right in the middle, a score of 5 or 6. This intermediate score mandates active clinical observation. It also triggers the strict requirement for definitive imaging to see exactly what is happening inside the abdomen. By forcing this calculation, the algorithm prevents arbitrary jumps to the operating room. It enforces an objective, evidence-based triage system for every incoming case. For those intermediate patients, radiological imaging, typically an ultrasound or CT scan, is required to physically confirm the inflammation and check for localized complications. The clinicians are specifically looking for uncomplicated appendicitis. This means the appendix is inflamed, but there is no localized abscess or hard calcified fecalith blocking the base. This flowchart outlines the management pathway for pediatric patients, which diverges noticeably from adult protocols in how risk is assessed and verified. For children identified as intermediate or high risk, there is a heavy reliance on initial ultrasound evaluation. The rationale here is to minimize radiation exposure. CT scans are actively avoided in the pediatric protocol unless atypical findings on the ultrasound require a higher resolution second look. Across both pediatric and adult cases, radiological imaging shifts the clinical process. It moves the diagnosis from a probabilistic score to definitive anatomical proof, which is the absolute prerequisite for considering non-operative treatment. Non-operative management, or NOM, is the strategy of using targeted antibiotic therapy to resolve uncomplicated appendicitis without surgical excision. This flowchart dictates the strict selection criteria to safely attempt a non-surgical approach. Factors immediately disqualifying a patient include active pregnancy, a lack of expected compliance, or the presence of a fecalith seen on imaging. If the patient is eligible, the primary clinical proposition is a specific, potent antibiotic regimen. The standard dosage is 1 gram of amoxicillin and clavulanic acid, taken 3 times a day for 8 days. This is administered orally unless nausea or vomiting requires an initial intravenous delivery. For patients with penicillin allergies, the protocol shifts to a secondary regimen, typically a fluoroquinolone like ciprofloxacin, combined with an imidazole like metronidazole. Non-operative management is a highly structured clinical pathway, not a passive choice. It requires rigorous filtering up front to prevent life-threatening infections from developing while the patient is at home. This diagram shows that initiating antibiotic treatment triggers a mandatory 24 to 48-hour clinical observation loop. At 24 hours, the team conducts a clinical reevaluation and draws repeat lab tests for white blood cells and CRP to gauge inflammatory response. If the patient exhibits a rising pain score, a persistent fever, clinical signs of peritonitis, or climbing inflammatory markers, the non-operative attempt is declared a failure, forcing an immediate crossover to the surgical track. This infographic captures the core debate, weighing the immediate appeal of avoiding surgery against the long-term efficacy of antibiotics. Excision guarantees a 99% success rate with almost zero recurrence risk. Conversely, antibiotics avoid surgical wounds and save hospital resources. However, that medical approach comes with a critical statistical trade-off. For uncomplicated appendicitis, non-operative management carries a 21 to 29% failure rate at 1-year follow-up. While the antibiotic pathway spares many from operative trauma, it transfers that risk into a statistically significant chance of delayed treatment failure and future recurrence. The operative management track is triggered in one of two ways, either an initial high Alvarado score of 7 to 10 or the clinical failure of the inpatient observation loop. Once the decision to operate is finalized, the preoperative preparation involves continuing intravenous fluids while administering broad-spectrum antibiotics and analgesics. As a safety requirement, the surgical team arranges a standard blood group and safe check, ensuring compatible blood is on standby for unexpected bleeding. At this point, the assessment phase abruptly ends, and the patient is rapidly transitioned into the operating theater. Every preoperative step is designed to optimize the patient's physiology, ensuring they can safely withstand the controlled trauma of physical excision. Patient comorbidities and anatomical variables determine which surgical modality the team employs inside the theater. This table lists indications for laparoscopic appendectomy, the minimal access standard for females of reproductive age, obese, and immunocompromised patients. Conversely, an open procedure is mandated for complicated appendicitis, generalized peritonitis, severe cardiopulmonary disease, or stump appendicitis. This matrix introduces robotic surgery as a third specialized option. The robotic approach provides 7 degrees of instrument freedom, tremor elimination, and 3D visualization. However, these benefits are weighed against severe disadvantages: high financial costs, steep learning curves, and complete absence of tactile touch feedback. Every phase of this process is linked, from baseline risk scoring through diagnostic imaging gates and antibiotic observation loops to final surgical extraction. Modern appendicitis management matches specific patient pathology to specific interventions through a series of diagnostic and clinical decision gates.